If you do have a question or comment for the presenters, you can enter it in the chat box to the left, and we'll go through some of those as we move forward in the webinar. And again, at the end of this, at the end of the two presentations we have today, we have allocated 30 to 45 minutes for Q&A. If there's not ample time, then of course we will take questions via email, and we can get you the best answers that we can. Next slide. So just really briefly, I thought I would review the agenda of what we hope to accomplish today. Just to welcome and some overviews on efforts to date on the CLIA waiver for rapid syphilis tests. Dr. Peter Leone, who's Professor of Medicine at the University of North Carolina and the former chair of NCSD's Board of Directors, will be doing the first presentation. Peter really has been our lead working with staff here at NCSD over the last several years on rapid syphilis, and he will be doing, again, an overview of the test and some of the reverse algorithm things which many of you may have seen before. Then Dr. Mark Thrun, the Division of HIV STD Prevention and Control at Denver Public Health and the Director of the Denver Prevention Training Center, as well as an Associate Professor at the University of Colorado Division of Infectious Disease, will be having a bit of a discussion with all of us about the implementation challenges, opportunities, and scenarios for the rapid syphilis test. As I mentioned, we'll have time for Q&A and then just some closing and future resources that we wanted to mention to you, which will be forthcoming on the RST. Before I continue, I do want to make clear that NCSD receives support from the two companies that have been involved in seeking CLIA waivers for rapid syphilis tests. That's Trinity Biotech, whose device, Syphilis Health Check, is the only CLIA waived rapid syphilis test in the U.S. right now, and then our partners at ChemBio, who are also working on a similar CLIA waiver. We do receive support from both of them, and I wanted to be clear that that was the case. Next slide. So very briefly, I just wanted to say how thrilled we are at NCSD that we have arrived at this point. I arrived at NCSD just over 4 years ago, and very early on worked to have NCSD have a greater involvement in prepping the field for a rapid syphilis test, working with our diagnostic partners to bring a product to market and to CLIA waiver, and increasingly focused on FDA advocacy work, which we hope was impactful in getting this first CLIA waiver and hopefully will be impactful going forward. The document that you see in front of you here, Rapid Testing for Syphilis, a primer for clinicians and other healthcare providers, is a trifold brochure that NCSD created with the support of Trinity Biotech several years ago, which was really just to prep the field and to get the word out there that it was possible for us to have this test on the market and that we were heading in that direction. We've also done several sessions at our NCSD annual meeting over the years, again preparing the field for what this might look like and working with our partners to pave that ground. And again, we just couldn't be more thrilled that we're at the point where we have this CLIA waiver for this device and excited to do this webinar for you all today, or with you all today. What I want to say before we continue is that what we're not trying to do today on this webinar is to create the definitive statement on what the RST means. There will, and I'll mention this at the end, some additional resources coming forward, but what we felt was really important is, given the CLIA waiver came in December, and that we know our partners at Trinity have been getting an enormous amount of customer interest in these products, and that products started shipping, I think, earlier this week, we felt it important to do a webinar and just really have a discussion with you about some early considerations for use. So again, this is not intended to be the definitive statement on this. It's really to be an opening salvo and to talk about the promised scenarios and challenges that this test offers us. So with that, I will stop and turn it over to Dr. Peter Leone. And Peter, again, thank you for your ongoing support to NCSD working on the RST, and the floor is yours.
Thank you, Bill. So just to reiterate what Bill said, and we're excited that we've got a kit that we've really been pushing for a while to have. I think it's a tool that sort of increases our ability to match what we need out in the field. I'm going to, in the next 15 to 20 minutes, quickly go over the kit itself. I've edited some of the slides that we got from Trinity of the kit. We'll go over just some of the data that they used to get FDA CLIA waiver, but I think we'll get into more data at some greater point, and I'm sure Mark will touch on the fact that we're going to need a lot more data in terms of how to use this, and the efficacy of the test itself is one that we have to find the right scenarios for. So with that, I'm going to go ahead and get started on the next slide. I don't know, Devin, if you can, there we go. This is not going to be a Syphilis 101 primer. There just isn't enough time. So again, I think the PTCs will provide a lot more information on syphilis, but I think it's important to just quickly go through serological diagnosis of syphilis, and we'll go through the reverse algorithm as well. In terms of diagnosing syphilis, syphilis is one of these infections in which you really need all the information: history, physical exam, and laboratory tests in order to make a decision. We frequently will err on the side of treatment. This, again, is one tool. So there's no definitive test that we can say is the perfect test. This test has to be put in conjunction, or at least in perspective, with how we approach the diagnosis of syphilis. And from a serologic diagnosis, we always require two types of antibodies. There's a non-treponemal antibody, which is really sort of a non-specific antibody directed against lipoid antigens, and then there's treponemal antibodies, which are specifically directed against T. pallidum proteins. Next slide. When we think about the antibody response, again, you have to think about sort of the staging of syphilis and what happens to these antibodies. So when we're talking about the rapid antibody test, we're talking about detecting T. pallidum specific antibodies. They go up early in syphilis in the primary stage, and we'll come back to that in a little bit because I think there's a caveat here that we're going to have to keep in mind as we start using this test, and remain elevated. So we don't typically use, and we can't use, T. pallidum specific antibodies for clinical management of syphilis. If a person has a past history of syphilis, that antibody test will remain positive. It won't come down. And so our non-treponemal tests are ways that we look at clinical response and allow us to monitor that individual for future reactivation or new infections. Next slide. So the conventional wisdom and what will be in the STD treatment guidelines that should be coming out this year is that we still use a non-treponemal test for screen. That would be a Trust, an RPR, or VDRL. It's inexpensive. It has a high sensitivity, and we have lots of experience with that. We know how to interpret that, and it does follow the clinical course of disease. And then we confirm with a treponemal test, which in the past had been the FDA antibodies, the TPPA, Western blot, and now we have a whole slew of different EIAs and ELISA assays, and now we have a rapid test. They're relatively expensive compared to the RPR, and they have a high specificity, but sometimes they can lack some sensitivity, and that seems to be particularly true in the case of the rapid test in primary disease. So I think again, you're going to still need to take a good history and do an exam where indicated, and certainly where we're seeing high incidence of syphilis, we're really going to need to think about how to place this test. Next slide. So which algorithm to use? There's the traditional approach, as we've talked about, and what we've seen more and more is reverse sequencing algorithms. That's been primarily driven by laboratories that do large screening of relatively low-risk populations. It can detect early and treated infections that might have been missed sometimes with traditional screening, at least in the case of some of these tests. The non-treponemal test is needed to detect active infection and then to follow what that clinical response is. So again, we do see false positives for these tests in low-risk populations, and that's always been the catch point, is how to interpret the use of this test. Next slide.
Hey, Peter, this is Bill. Can I just ask you to move to the phone a little closer? We're getting some requests for you to speak louder.
Okay. How's that?
Thank you. That's much better. Thanks.
The challenges and limitations of the EIA assay is that you really can't distinguish between active disease and old disease, so someone who's been treated or not. So when we use this point-of-care test, we're going to need to know a person's past history of syphilis. If they have a past history of syphilis, this is not the test you're going to be able to use. Studies to compare test performance with other serologic tests are still lacking, although now we're starting to get better comparisons of all of these tests head-to-head to see how they could be used, what's sensitivity, in particular how the sensitivity and specificity matches the stage of disease. And then the last point here is one worth mentioning, which is that there's been still ongoing confusion about the management of patients with discrepant serology. So if they have a positive EIA or in this case a rapid test with a negative RPR, you're still going to need to do another test in order to determine whether or not this person has syphilis or not. And that would be, again, another treponemal-specific test. Next slide. I'm not going to read all of this. It's available on this slide set to say how do we interpret the traditional approach for serologic testing. Next slide. But what we're really talking about here is using a rapid test, which is really following the reverse sequence. So the traditional approach most of us are familiar with, but we're now going to go through the reverse sequencing. Next slide. So in the traditional approach, you examine a patient. If they have a lesion, then you might actually either do a dark field if that's available, but you would treat that person no matter what the test result if you suspect that they have primary disease. You would then do a non-treponemal test. If it was non-reactive and they had a lesion, again, we would treat, but we would repeat this in a couple of weeks. If it's reactive, then you would titer it out and you would confirm that with a treponemal-specific test. Next slide. For the reverse algorithm, in this case, you would use the rapid test. If it's negative, we would say that person is negative for syphilis. The caveat here is that at least in some of the reports, and there's one that I would refer you to that was in PLOS in 2014, Kauser's the first author out of Australia, in which they found a decreased sensitivity with primary disease with rapid tests. Now, there was variation with the different tests, but it looked like that sensitivity was around 80 to 90%. So again, I think we're still going to need to put our clinician hats on when we're using this test, ask about lesions, maybe consider doing an exam to look for a primary chancre. But if it's positive, you then need to follow this up in this case with a non-treponemal test, either an RPR or a trust. And we would say that that person then, if they're positive on both tests, that would be consistent with syphilis, and you would stage them accordingly. If they're negative, now you've got discrepant results, in which case you need to do a second treponemal test that would be the tiebreaker. And I would refer you again to the MMWR articles on this to help walk you through, and I'm sure this is covered well in the upcoming STD treatment guidelines. Next slide. So where do I see the point-of-care test? And Mark's going to spend a lot more time on this. Again, this is basically similar to what we just went through, and that if it's positive, you still need to do a RPR or trust. In those clinical settings, though, you would either treat that person presumptively if they were high risk or if they had physical exam or historical findings suggesting that they had syphilis. The goal here is to treat people before you lose them. Or if we were doing this, say, out in the field, we would then interview that person for further contacts and might bring them in for further testing. Next slide. So here we are with the syphilis health check. And it is a qualitative rapid assay for the detection of T. pallidum antibodies. And it can be used as an initial screening test, but it needs to be done in conjunction with non-treponemal tests if that's reactive. And certainly, again, clinical information is critical. Next slide. Now, the performance of this assay looks pretty good. And looking at data that they had and samples that were collected from 5 sites of folks that either were known or suspected to have positive samples, meaning positive RPRs and trusts, they had an agreement here that was pretty good. Positive agreement with reference treponemal tests of around 98%, negative agreement with reference tests of around 97%, and overall agreement of around 97, 98%. Next slide. With a panel of 164 clinical diagnosed samples that were from one clinical site, I believe, in this case, and these were folks who were untreated with primary, secondary, or latent syphilis infections, but did have reactivity based on our traditional testing. There was 100% agreement in this case in all 164 samples that were tested. Now, those numbers, if you break this down, aren't going to be large, and again, I think we're going to need more information down the road. But what I can say with some degree of confidence is that the test functions pretty well out in the field. Next slide. So what are the advantages to doing this particular test? Well, it's a third-generation EIA, so it detects both IgG and IgM, which we think would increase the sensitivity for early disease. It does utilize multiple recombinant syphilis antigens, which are listed here. It takes 10 minutes. You can store the kits at room temperature, and more importantly, in our case, it's CLIA-Waived. And we've already talked about agreement with reference treponemal assays. Next slide. The kit itself will come with 20 check test devices, 20 disposable plastic fixed volume pipettes. There will be one diluent in a bottle. And then again, you can store this at room temperature, and temperature here is listed up to 86 degrees Fahrenheit, and it has a 2-year stability from the date of manufacturing. So this is a pretty easy test for us to store and to hold on to. Next slide. The control kit here comes as a 1 bottle for positive and 1 bottle for negative control. Again, 2-year stability, and in this case, the control needs to be refrigerated for storage. Next slide. The materials that are required that they provide are listed here. Obviously, you're going to need some other things, but I think it's worth pointing out that if you require a timer and you don't have one, you can actually ask Trinity Biotech for one, and they will give it to you. At least that's my understanding. But this is what you get, at least with the health check. It is a finger stick procedure. It can be used on whole blood. Next slide. So the assay procedure itself, pretty straightforward. You got to let the kit and the control come to room temperature prior to testing. You want to obviously remove the kits from their wrappers, fill it out, and then you're going to actually do a stick. You want to actually absorb the samples onto the pad after you pick it up into the pipette, which I'll show you here in a second. After you've done that, you would add 4 drops of the diluent into the sample well. 1 more drop can be added if the sample doesn't flow all the way up the membrane. You're not to use water to do that. You set it on a flat surface and incubate it at room temperature for 10 minutes. Now, the important thing here is that it can be read from 10 to 15 minutes, but it's not reliable for reading after 15 minutes. So the timer becomes really critical here, and that you've got about a 5-minute window to read it, and it's important not to sort of walk away and forget about it. Next slide. So pretty straightforward with a finger stick here. You want to get a full drop of blood before starting the collection. Next slide. Pull it up into the pipette. You do want to fill that pipette to the black line that's on there. Next slide. You would dispense the entire sample that's collected there into the well, and then allow it to be absorbed into the membrane. Next slide. We then add the drops of the diluent, and then you want to make sure that the timer is then set after you've added the last drop. Next slide. And then this is what you would get in terms of test interpretation. You can see in this case there's a mark there on the control side with a red line, nothing on the test side. That would be a negative test on the left. On the right, you can see a positive test. Next slide. And you know, the critical thing here is that control line really needs to pop up. So that should be positive no matter what. Next slide. So as I've already mentioned, the materials that are required are listed here, and you should be able to get all that in the kits. Next slide. Here are, again, positive and negative controls. Next slide. What about the cost? The cost that they provided, at least, and maybe there might be some room for more negotiation around the public health price, is that for the health check kit itself, there would be 20 tests in a kit. That's $400, so that's $20 per test. That's separate. The controls then are $53 a box with both positive and negative controls. The CPT codes are listed there, and the reimbursement rate for doing the test is $18.06 per test. Next slide. So I quickly went through the test itself. I would again finish up with saying that we think that this test will work well in the right scenario. I don't think that this is a test in which you can just use it without getting some history. It's going to be important to obtain a history of syphilis or past syphilis treatment from a patient. But in the right settings now with point-of-care testing for HIV and hepatitis C, this is one more test that would allow us to move things out into a clinical setting and out into the field. The one caveat here in positivity, or at least the sensitivity aspects of it, would be in primary disease, and I think we're just going to have more experience to see whether or not that sensitivity is going to be similar to the issues that we have with the RPR, in which about 10 to 20% of the time we have a negative test in the case of a primary lesion. So with that, I'm going to turn it over to Mark, and then I'll hang around for some questions at the end.
Great. Thank you, Peter. Can I just confirm, can you hear me okay?
We can, Mark, yep.
Okay, great. So I'm going to actually speak about the aspect of this test for which there's very limited science, but a lot of anecdotal use case scenarios from lots of developing countries. And so I'm going to talk about where and how and where not we might be implementing this test. Next slide, Devin. So I'm going to talk briefly about who gets syphilis. Peter sort of discussed this a little bit. I'm going to go into a little bit more data at the national level from the CDC. We're going to talk about use cases for primary screening, and then also discuss use cases for immediate screening and confirmation. So getting both a triple-nemal and a non-triple-nemal test right in the same moment. Next slide. So who gets syphilis? Well, predominantly in this country as of the last decade and a half or so, it's been men who have sex with men. You see that in the solid line on this graph from the CDC from 2013, even though I think each of these says 2103. I was about 100 years early, I think, in putting together this data. Hopefully this won't be the curve 100 years from now. You'll see that men who have sex with women is the lighter gray line, and then women down below. This is really a disease in the present day, primary and secondary syphilis. That syphilis that we worry about in public health as being contagious, as being transmissible, is really a disease of men and of men who have sex with men. Next slide. The rates of primary and secondary syphilis, again, what we worry about in public health because it is transmissible. You'll see these by the rates by region here. We've seen an increase in all regions in the United States, some more dramatically than others. Next slide. You also see that this is a disease that impacts mostly men, as shown on the left, as I already mentioned on the slide previous, but men who also are in the age range in which they might be at risk for HIV. And so it's folks in that 20 to 24-year-old group, 25 to 29, and then into their 30s and 40s, as you'll see by the size of those bars on the male side of this graph on the left-hand side. And so that's really who we're thinking about when we're thinking about primary and secondary syphilis in this country. Next slide. The locations for where syphilis ends up being diagnosed vary. you'll see there's three different populations here: men who have sex with women, and then men who have sex with men. That's the three different clusters of bars. Correctional facilities, HIV counseling and testing sites, and then private physicians and STD clinics are the bars within each of those domains there. And you'll see that the majority of syphilis, primary and secondary, early syphilis, is diagnosed either in private physician settings or in STD clinic settings. So settings in which we're seeing folks at risk for syphilis, and settings in which this test might potentially be useful. Next slide. So how do we think about who is at risk for syphilis? Well, if this is the overall clinic population or your jurisdiction's population, next slide. This is the population of folks that are at high risk for syphilis. That's sort of the domains that I just talked about: men who have sex with men who have sex with men who are presenting in STD clinical settings, men who have sex with men presenting in STD clinical settings between the age of 20 and 40-ish. That is that population that falls within there. Next slide. But then there's all kinds of individuals that might be at high risk for syphilis. And so you may have a heterosexual woman that doesn't fit into those domains that I just described, at risk for syphilis simply because she just had sex with a man who had syphilis. And so though she might be that little dot outside of that high-risk group, clearly merits screening for syphilis and potentially just treating as a contact. I'm going to shift from sort of the higher-level epidemiologic data, though, to the individual-level data on the next slide, please. So at the institutional level, who is it then, based on what we've just described, that ought to be thinking about implementing this test? Well, you really have to ask yourself some questions and think about it, either within your jurisdiction if you work in a health department, or within your own clinical settings if you work in an agency or a clinic that offers STD screening. You really need to be serving the population at risk, obviously. Some of these are sort of commonsensical. Do you already have the right facilities to be able to be using this test? Do you have the capacity to conduct syphilis testing, period? Is that already being done? Are you already using another ELISA? Are you already using an RPR? i.e., is there a base knowledge around syphilis screening in your clinical staff and in your laboratory staff or your outreach staff? And then whether or not you would decide to implement this test really will depend upon the type of facility, the capability, the caseload. It's not going to be a test that's right for every clinical setting, and I think that's important to recognize. Point-of-care tests, just because of their nature, because of the tech time involved, tend to be a little bit more expensive than tests that can be put on a big mechanical analyzer and the results just automatically outputted into a computer program. And so one really does need to think about the right utilization, and of course this is a cost-benefit assessment at your own individual clinic or within your own jurisdiction discussion for you all to have. And then obviously you need to assure the right logistics, training, quality assurance measures are complied with. You develop those protocols. Next slide. So can point-of-care syphilis testing be adopted? I think if you go through those questions and you think about it as an institution, you answer yes to most of those, and you've begun to develop protocols, and there'll be future work on this by the NNPTC as well as I suspect by NCSD. I think it's possible. Next slide. So at the patient level or the individual level, as I had referenced, in whom would point-of-care screening for syphilis be useful? And by this I mean primary screening. So somebody who's coming in from the community, and this would be the first test that we use. Well, clearly you want people at high risk for syphilis. And so pregnant women, people in which we really need to know their syphilis status. Obviously, before people deliver, we want to know whether or not they have syphilis. Individuals with or at risk for other STDs, so folks that are coming into STD clinics, as the data on a prior slide from CDC sort of underscored. Sex workers, again, people at risk for STDs, clients of those sex workers, injection drug users who may be injecting and then being disinhibited and having sex either for the drugs or because of the drugs. And then obviously, as I've already underscored, men who have sex with men who have higher prevalence rates and higher incidence rates of syphilis ought to be considered for this test. Next slide. Who is it not useful for? And I appreciate Peter describing this very well in his segment of this presentation. In fact, anyone with a past history of known syphilis, either treated or untreated, this is not the test for them. because antibody can be positive for your lifetime, if you've already had syphilis, this test is going to be positive, or there's a great likelihood that this test is going to be positive. So it's not going to give you any new information about what might be going on for that patient right now. So thus, next slide, I agree with Peter that the protocols need to be developed which does incorporate an element of the history. We need to either, whoever's doing the screening or the triage needs to ask persons prior to using this test if they've had a history of syphilis or a history of treatment for syphilis or something that sounds like a series of shots for syphilis, or we need to build tools through our EMRs that either search or ping medical records for prior positive syphilis tests or treatment. We don't want to be using, it would not be a good use of healthcare resources to be using this test in a population of folks that have already a known history of syphilis. Next slide. So the WHO actually put out recommendations back in 2006. That's how long actually the tests have been used in developing countries for many years prior to that. The WHO put out the recommendations that I'm going to, or the thoughts that I'm going to share on the next couple of slides in 2006, quite a while ago. They suggested the following for primary screening protocols, that in settings in which it will not be possible to get another test, you could use this. Note, I don't think that's likely to occur very often in the United States. There's almost always the opportunity to get a confirmatory test, or at least that should be the way we write our protocols in this developed country. So I don't think that this case scenario is going to be commonplace here in the United States. Possible, but not likely to be commonplace. Next slide. Thus, this is how I suspect this test will be utilized, and I'll spend a moment on the graphic on the right, for primary screenings. So in settings in which it will be possible to get a confirmatory RPR, i.e. most settings in the United States, this is what we would do. And this is sort of what Peter has already walked you through in the reverse algorithm in his slides previously. We would get blood. We would perform the point-of-care rapid test. If it's negative, it's negative. And outside of the scenarios that Peter has described, perhaps in primary syphilis where we worry that just not enough time has gone by for someone to develop an immune response, it likely means, except for that scenario or situation, it likely means that the person is negative. But if they have a positive test, we would then confirm it with an RPR. That would also allow us to begin to stage the disease and be able to get a baseline RPR so we can follow treatment. If that's positive, we would treat. If that's negative, we'd either repeat with another treponemal test, or we would simply repeat the test as the World Health Organization recommends in 6 weeks. I think that remains to be seen. I think in most settings in the United States, we would simply proffer a third test, another treponemal test like a TPPA, and then if that is positive, we would treat them. And so I think this is the scenario, the reverse algorithm scenario, that I think most of us will likely utilize as we think about using this point-of-care test, the rapid syphilis test, for our primary screening purposes. Next slide. So in what use scenarios would this test be useful? We talked a little bit about the populations, and so it's where those populations might be being served. In outreach screening, many large jurisdictions still have significant outreach screening programs specifically related to HIV, and as I've already mentioned, there's a significant overlap between those who are at risk for HIV and those who are at risk for primary and secondary syphilis in this country. And so outreach screening programs that are offering HIV testing, this would be a great addition to those programs because they're probably reaching out to men who have sex with men and other people at high risk for STDs. Obviously, in a peripartum setting, if a woman comes in and had no antenatal care, we've not yet done syphilis screening, this would be an ideal test. In most of the settings, you could very quickly follow up with a confirmatory RPR and be able to very quickly know someone's syphilis status before delivery. So you could actually not only primarily screen, but you could potentially confirm the diagnosis, and I'll get to that in a second. And then obviously settings in which syphilis incidence or prevalence is moderate or higher. So clinics serving men who have sex with men, clinics serving IDU or persons exchanging sex for drugs or money, STD clinic settings. Next slide. So it can also be used, as I've just referenced, for confirmation. And so if you have the ability to both do this point-of-care test as well as a stat RPR, you could potentially be done screening and confirming a patient all within the same visit, be able to offer them treatment in that visit, and potentially be done with the syphilis management for that patient in the short run if they had early disease. And so when stat RPR is also available, it does allow for immediate treatment. And indeed, I'll show you some data from Texas where this was recently piloted. In those settings, it was piloted in the traditional sequence, so an RPR followed by a treponemal test. But as both of these tests could, in essence, you wouldn't want to do them both at the exact same time because that would be a waste of money. But in very quick, rapid succession, you could do both of these tests. And so it's also reasonable to perform in the reverse sequence, as Peter described. Start with the rapid test, follow up with RPR. Next slide. So in Texas, there are 4 clinical labs that were coordinated by the Texas Department of State Health Services under the Syphilis Elimination Coordinator. I have very generously borrowed, she's very generously allowed us to borrow these slides. They performed stat RPRs in-house. For those people that had a positive stat RPR, they then performed the rapid syphilis test, the syphilis health check. And so next slide. And this is what they found. So there was 225 syphilis health check tests that were conducted. The age was about, the median age was about 34, 25% were female, 75% were male. The demographics you see here appeared to be relatively reflective of urban areas in Texas, or many urban areas, not all of them, I guess, in Texas. 31 folks out of the 225 were co-infected with HIV, and there was 170 cases of true syphilis that were identified, 27 primary cases, 54 secondary cases, 62 early latent, and 27 of unknown duration. And so these, again, were all folks that had a positive RPR. They then had the syphilis health check, the rapid point-of-care test performed, and they identified 170 cases. Next slide. What that means is that they were also able to identify 34 biologic false positives. And so people that had a false positive RPR who subsequently didn't need aggressive follow-up or treatments because they were just false positive RPRs. Several of those were identified due to pregnancy. They overall, because they were able to perform both of these tests immediately in rapid sequence, they were able to save an average of a little over 5 days awaiting TPPA, and thus were able to give treatment early. In fact, 82% of them, 82% of the 170 true infections were treated in the same day. Next slide. So its potential use settings as a confirmatory test, well, STD clinics, I think this is a little bit more complex. We need a place in which there is also a lab, the ability to be able to perform a stat RPR. And so STD clinics, peripartum settings in which a patient has had, again, no antenatal screening, urgent care emergency departments. Again, many of these might be also places where patients are not expected to follow up in a primary care manner. Some HIV clinics where stat RPR is available, I suspect those clinics may be few and far between. Clearly, we see a large proportion of folks within HIV clinics who are at risk for syphilis. But in those settings, oftentimes standard ELISAs or an ELISA that's batched and performed on an automated machine might suffice. And so with that, I think I am about to end. I think I had a couple more slides, but I think I just had, oh, yeah, there we go. Conclusion. So it's a great opportunity. I think the point-of-care test provides great opportunities for point-of-care screening for syphilis in high prevalence populations and settings, the populations that we just described, men who have sex with men, injection drug users, pregnancy sex workers and their clients, and outreach settings where we're reaching out to MSM or IDU or sex workers, in emergency and urgent care where we need that diagnosis today. That might be helpful in STD clinics where that diagnosis today could be helpful. And then I think could also be used for immediate diagnosis and confirmation in high prevalence settings such as STD clinics, ERs, urgent cares, peripartum STD clinics, HIV clinics, some HIV clinics. But I again will bring you back to the very last slide, and that is it shouldn't be used for those with a history of syphilis. And so I think that each institution is going to have to think about their own cost-benefit analysis, how they might implement this test, and again, how they might implement or how they might figure out within their own protocols how to screen out those that have or take those people out that already have a history of syphilis before using this test, as it would not be the right test in that setting. So with that, I am now done, and I'll turn it back over to you, Bill and Devin.
Thank you so much, Mark, and thank you, Peter. We're now going to move to some Q&A. What I would ask, we have about 150 people on phones. If you could go ahead right now and manually mute your own telephone on your end, that will help with background noise. So please go ahead and mute your phones on your end. And then we're going to go ahead and unmute the phones for Q&A. You can use the chat function to your left. We're screening those and looking at those, and we've got a couple questions lined up already. And you can also do it via telephone once Devin unmutes the lines. Why don't we go ahead, let me go through some questions here.
The conference has been unmuted.
We've got some questions lined up here. So Stacey Holly, please go ahead and mute your phones, otherwise we're going to have to remute all the lines. Devin, I think someone has us on hold, so why don't I ask you if you can to go ahead and start muting lines again, so you can figure out which one that is. Stacey Holly asked a question, under what circumstances would you treat positive SHC, no confirmatory available?
The conference has been muted.
Peter and Mark, can you hear me? Bear with us one moment, sorry. Peter and Mark, are you there? Okay, everyone, bear with us just one moment. We had to remute all the lines due to the background noise. Someone had us on hold. Peter, are you there?
Bill, it's Mark. Can you hear me?
Yes, Mark. Thank you.
Oh,
yeah, did you have an answer for Stacey?
Yeah, I think this is probably a question better for Peter. So when he is able to speak, I'll defer back to him. You know, I think that with any test in medicine, it depends upon the pretest likelihood of disease. And so if you had somebody that was coming in with a very clear-cut primary or more even clear-cut secondary lesions, and then you had a positive rapid test, but you were not able to confirm that in the moment, I think you would go ahead and treat, as we would oftentimes do based on the clinical scenario anyway. I think, however, if somebody came in with very limited risk factors, they were a heterosexual who's been in a long-standing relationship, who doesn't have significant risk factors for syphilis, in those cases I would probably wait for the confirmatory test as opposed to moving ahead with treatment. Regardless, I think you're going to want to search for you're going to want to get the RPR regardless. You're going to want to be able to stage that person. So though you may not have it available to you, even in those people you treat, I think you'd still, you would still want that data from that moment.
Thanks, Mark. Peter, do we have you yet?
Yeah, I don't know if you can hear me or not.
Yeah, please, go ahead. Yep.
No, I agree with Mark. I think the issue here is that you don't want someone leaving who you think might be infectious. So if they have a lesion or a history of a lesion or a rash, something that would make you think that they had recent primary or secondary syphilis, you're going to treat them presumptively. I would add that if they were a contact to a known early syphilis case, I would treat them. So, but otherwise, I think if they don't have a lesion and this is a low-risk population, then you want to do a confirmatory test and try to make sure you educate the person that you need more information.
Great. Thanks, Peter. Everyone, if you've got questions, please put them into the chat function. We're not going to be able to unmute all the lines due to the background noise. We have another question here. It says Ann Rumpalo, but I'm told that it's from Terry. So the question is, how did the lab in Texas confirm the biological false positives? Did they use the rapid? And isn't there evidence that the rapid test is not as sensitive in early disease? So why would you use that as a confirmation for a biological false positive?
So I'll answer the first part. I don't know exactly, Terry, what exactly they did in Texas. My understanding is that they really flipped those to a third test, another treponemal test, and so that's what they were using then as the decider. But with that, Peter, I'm happy to take a stab at the sensitivity question, but I might appreciate if you wouldn't try that first.
Sure. I think it's a good question, Terry. I think it would be a problem to use it where you suspect biologic false positive. The issue here is that the sensitivity of the test is a problem with primary disease. So it may be that you just need to do a good physical exam and hopefully get a reliable history. The problem we get into, at least in non-pregnant women, would be, most guys in particular don't notice lesions around their perianal area a lot of times, or even women may not notice intravaginal lesions. So I think it might make sense, but these are the types of things that we're going to have to sort of work out with an algorithm to really understand how do we use this test in these cases. And where it might be helpful, if you really have someone who you're not sure about and you're worried about, you might treat them presumptively anyway, but that would give you a little bit more reason to go ahead and treat them. I don't know, Mark, your thoughts?
I think that's right. I think the challenge is going to be in I think the challenge for this test is going to be in low prevalence populations, as well as very early in disease. But I think that those challenges are not unique to this test as opposed to antibody testing for syphilis, and where we often have to triangulate data to get to a diagnosis using a couple different tests as well as the clinical scenario. And so I'm not sure that this test offers such greater challenges, a greater array of challenges than we already face. It's just that I think that there's the potential for this test, wisely so, to be taken up by an expanded array of organizations and folks interested in doing well by their community by providing point-of-care syphilis testing, and they may not have the clinical background necessary to fully interpret the test wisely. Did that make sense?
Mark, it absolutely did, and I think, as you know, this is one of the reasons we really wanted to do this webinar very early on as products getting shipped out, because the context for use is super, super important.
I'll also add, Bill, I think, we've had some conversations offline as well. What we really are going to need as health departments and as clinicians that specialize in STD are for us to take the lead on developing some protocols, because there are going to be non-clinical organizations that would love to be able to use this test, and I think the imperative will be upon us to try to make sure that it gets used in wise settings, and that we have resources for those organizations to call upon when they do get the challenging results and the confusing results back.
Yeah, and I would add on to what Mark said. I think where I really envision this being quite useful is that we've got a lot of non-traditional testing sites in places where we have high prevalence of both syphilis now and HIV. And it had been a barrier to have to draw blood for syphilis. We've stated in North Carolina that it was really critical that if they did an HIV test, they got a syphilis test as well. That became a problem in places that did not have a phlebotomist available. So I think there's a real niche here that can allow us to increase screening, but we're going to have to provide good education, this is sort of the start of that, as well as support. And I think that there's a real role for the STD clinics as well as the PTCs to provide that sort of backup about how to interpret these cases. And many of us have been doing this anyway with use of the reverse algorithm. I mean, we get phone calls about what to do with discrepant results or what to do with this pregnant woman who's, been in a mutually monogamous relationship with someone who does not have syphilis. So it's not perfect.
Yeah, thanks, Peter. And let me just also add that Mark just hit on one of the things I mentioned we talk about at the end, which is some of the future resources that NCSD and NNPTC have already talked about aside from this in terms of future resources that are needed. And I'll say a little bit more about it, but Mark hit on it. It's really some of these, some of the tools that we know perhaps non-traditional providers will need to use this test accurately. And we already know, for example, that a lot of CBOs are asking questions and interested in ordering this test, and that there may be some additional training that's going to be needed there. And I should just dovetail that with a comment from Charlotte Gatos that she's confirming that we need training for new users of this. And Charlotte, we couldn't agree more, and I know you're going to be involved in some future work with us on guidance on this. So yes. So let me ask a question from Sue Blank over here in the chat function. So Sue asked how the rapid test performs in the place of a history, either past or current, of Lyme disease or other treponemal diseases. Can either of you answer that one?
I don't think we know.
I don't know that we know either. But that's a
good... Sue, I'm not... No, go ahead, sorry.
I was just going to say that's a good question for us to take back to the manufacturer, though, because I think we need to know that.
Yep, absolutely. Sue, we'll get a question for you on that and send it back your way. There's a question here from Daniel Pohl. I'm sorry if I'm mispronouncing your last name. He's just noting that it's really important as we think about where to use the RST, that because there's less of a history of syphilis among younger people, in particular younger MSM, that might be a more ideal sort of focus for MSM outreach than perhaps just a general outreach among 30s or 40-year-olds. Do either of you want to comment on that?
I think that... go ahead, Peter.
No, I agree.
Yeah, as do I. I mean, I think, as you get into an older MSM, into the older MSM age groups, this test may still perform well as long as they've not had a history of syphilis. But, of course, the proportion of folks will go down as they get older that have not had a history of syphilis. And so I think that's absolutely right, and I think that's also where we've been thinking about trying to focus our HIV testing a little bit more, which is on younger MSM who are still years from progressing from their HIV infection to an AIDS diagnosis. And so I think this matches well with what we're also trying to do in HIV, which is try to get people earlier in their disease.
Yeah, and I think this idea of bundling tests really becomes an attractive means to really start talking truly about sexual health and not just focusing on just HIV alone. And for us, dealing with black MSM in the South, we really need to be able to broaden this thing out as much as possible, because the idea of just coming in for an HIV test is not appealing sometimes to folks. And if we can bundle that now with hepatitis C and syphilis and HIV, you begin to really sort of broaden out why you're doing this, and you're not necessarily identifying someone as, oh, well, that person's at risk for HIV, and that's why they're getting a test.
Great. Thank you, Peter. Let's see. Julia Schillinger has a question. Why is the RST less sensitive in early primary syphilis? Doesn't it make sense, given that treponemal antibody, it doesn't seem to make sense, given that treponemal antibody may appear earlier than non-trep?
Yeah, again, I agree. I mean, when you look at all of the, we had traditionally used like the FTA or TPPA in cases in which we had a negative RPR and we thought this person had a primary lesion, that those actually came up first. I really think we need more data on this particular test, being it captures both IgG and IgM. I'm sure Charlotte probably is much better equipped, I'm positive of that, to answer that question. But it may have to do with some of the antigens or antibodies that are being targeted, what antigens are being used.
Great, thank you. There's a question here which strikes to the heart of the STD program, so I'm not sure we have an answer for it, but I want to read it. So Stacy Holly asked, are there any project areas where DIS are able to conduct this test? I don't know if either of you want to answer that directly, but I'm happy to follow up on it.
So the product is not shipped yet, is my understanding.
I think it started going this week, but
okay.
So maybe it's in a few hands, but yeah.
I know that I've heard anecdotally of a few DIS that have interest in doing this. Obviously, again with the caveats that we've already discussed, and when they're interviewing partners or people in the community that have no history of syphilis, this could potentially be used and would allow them to be able to give immediate feedback to that person that they're not able to do at the present moment with regard to syphilis. So I think it's an enormous potential tool for DIS. We've begun to have some discussion with a couple of our DIS colleagues here in Denver as we begin to think about moving this test forward very specifically in outreach settings and making sure that we bring them in to have those discussions to figure out what their specific challenges are and opportunities are with regard to this test. But I've not heard of any jurisdiction as of yet that is using this test in a DIS setting. But I think it's a huge potential tool for them.
Yeah, I think that becomes something that would be fun to design sort of an intervention to evaluate its use that way, because I think, the barrier's always been trying to get folks in to get blood drawn. It becomes much more compelling if you're able to bring them in and you get a positive test. Now, in North Carolina, we've been doing field HIV tests as part of contact tracing. So I think with the right script, meaning asking them about lesions or whatever, it may be that we can get a better yield by trying to bring people in with positive tests. And I saw, just jumping ahead, that someone had written, I don't know if Rick Hedenquist is on or not, but it seems to be off of somebody else's name, but hi, Rick, if you are. Jail screening had been a barrier for us in terms of doing it, where we drew blood and then didn't have the results back prior to the person being released. So having this in a setting in which you really might lose someone, even if it doesn't perform as well in early disease, which I don't think would be an issue so much in jail screening, would make great sense to be able to do that screening test right then and there before you lose half your population within the first 48 hours.
Thanks, Peter. Did you want to say anything else further on that correction screening question?
No. I don't know,
okay.
Mark.
Yep. I'm sorry, Mark, go ahead.
No, it's okay. I actually can't see the question, so I'm not sure what the...
Oh, okay. Let me just say, Stacy, that we totally agree here at MCSD with both Peter and Mark. And one of the things that we've been talking a lot about internally, but also to our industry partners, is investing in some of the research to promote the promising practices, including work by DIS. So, again, we think there's really incredible potential there, and our hope is to play a role in getting some of those promising practices out, either through webinars, fact sheets, and certainly at the NCSD annual meeting in October.
And I would add that getting the CLIA waiver was really critical. It sets a benchmark now, and I think that might help us with other diagnostic tests that come up. I mean, it's really been critical to have that happen. And, again, we're going to have to figure out now how best to use it. But I think the exciting part is that we've got something that we could use in these other settings.
Great. Let me just, Rosemary Collins asked a question about how soon we can expect these tests to be in local health departments. Rosemary, apologies that I don't know exactly where you're located, but we would suggest that you get in touch with your state STD director, or more directly, you can get in touch with Trinity Biotech, and we will send that contact info out after the webinar is over so that you do have a contact there. Again, what we do know is they started filling orders this week, and product is being shipped. Let me do a quick question. I think this is Terry Hogan again. Terry's full of them today. I know that's a shock to all of us who know her. For the purpose of research to determine how well the rapid test is identifying early disease, wouldn't it be better to study a reactive RPR, the rapid test, and doing a confirmatory treponemal? And connected to that, let me just throw this one in since it is always the question, is what does the recommendation of the reverse algorithm mean, and is the CDC recommending that at this point?
So the second question is easier than the first. So the reverse algorithm is simply using an ELISA followed by an RPR, as Peter relayed, as opposed to an RPR followed by an ELISA. The CDC put out a fair amount of information about it several years ago. It's referenced in the STD guidelines. Indeed, it's the way many large labs, because they can batch ELISAs and they can do them in an automated way, it's the way vast majority of syphilis tests in primary care clinical settings are likely being performed in this country. I don't think there's arguments to and fro with regard to which test to use first, and that sort of then segues into Terry's first part of her question. And in my opinion, the more data, the better. And in fact, if we were doing a true sort of piloting of this, I would want to look at its performance against both an RPR and another treponemal test, frankly. And so we would probably we would do both, which is, again, what my understanding is sort of what they did in Texas. I don't know, Peter, your thoughts on either of those?
Yeah, I mean, I think what you would do is exactly what you've outlined, what Terry was alluding to, which is you really need to compare it across all of those tests. And then I think it's going to be really important to know what the stage is in response, because that, to me, becomes really the critical piece about even what questions to ask. And so we already know about a past history. That much is close. So it really is about focusing on primary disease and performance for all other stages of syphilis. And I suspect that this test will do well on all the other stages, but we really need head-to-head comparisons with RPRs and see what we get, and also obviously with traditional treponemal tests.
Thank you, Peter. Maybe just time for another question or two. Ashley Scarborough is asking a question that I know we have had side conversations about the role of this particular test in the goal of eliminating congenital syphilis. So Ashley says, we've seen some data in California from Kaiser demonstrating biological false positives in pregnancy with treponemal EIA. Are either of you aware of any data for the performance of the syphilis health check in pregnancy?
No, I'm not. And indeed, I do think that is something, I think that's true. I think that's always the clinician's conundrum when you get an EIA that's positive in a pregnant woman, and we very quickly try to figure out, again, triangulating using other tests, whether or not that is a true positive or a false positive. And so I think, again, it's a great place that we need more data. But I think there's the utility, the potential long-term utility of a point-of-care test in that setting is enormous. And so for someone that's coming in, peripartum, about to deliver, has not had antenatal care. So it's something that I think that we need, that the sooner we get an answer to that question, the better.
Yeah, and I would add that at least the data I've seen in the past were really with lousy sensitivity of the rapid test in developing world settings, in which case there seemed to be a real impact on reducing congenital syphilis if you were able to treat. So I think it's not just about a tiebreaker or screening low prevalence settings, but really trying to capture this group of women who might be out of care, who are at particularly high risk. And at least our experience here had been in North Carolina that the number one risk factor was actually not being in prenatal care. So in settings in which you're worried about having that person leave, say they come into the emergency room and they're pregnant and they have no doctor for primary care or had not been going in for prenatal care, that may be the right setting where you have a high enough incidence of syphilis to use this, and you'd be willing to live with whatever it is because it's better than nothing. So I think we really need to tease out and design the right studies and try to actually look at impact. And it may be that you don't need the performance if you're targeting the right population.
All right, thanks to you both. there is time here for another question or two if folks want to put it in. Chrissy Gerard has asked, will there be any potential funding to fund pilot projects? Chrissy, I think as you know, NCSD works pretty doggedly with our industry partners to try and get them to support things like that. So we'll continue to talk to our industry partners about that. I think it's also an interesting question on once there might be some larger uptake of this, whether or not there's some funding from the federal level, from the state level that we might be able to use as well. I can say here at NCSD, our policy staff has already begun thinking about is there an opportunity for us in addressing the rising syphilis numbers, perhaps to try in this crazy Washington environment to find some additional money that might be allocated for some of you to do that work. I think that's a pipe dream, but I think if we're able to continue to talk about that and the needed resources to do some pilot projects to really scale this up, it might be helpful. Okay, I'm not seeing any other questions coming in, and we are about at time. What I will say is for those of you who've asked some questions and we didn't hit on them exactly, we will get answers and send them back out to you. Again, as a reminder, the webinar recording and the slide set will be available after the call. And let me just say a few things about what you can expect going forward in terms of future resources. So the first is, as Mark touched upon already, NCSD and NNPTC I think are really excellent partners to work together to provide some national leadership on this. So we've already talked about the need for documents and other resources for providers, other healthcare personnel, including DIS, community-based organizations, all of whom we already know are really interested in this test because they're trying to do really good by their patients and by their clients, but may need some additional direction around how to use it well. So that includes things like a little bit more probing questions in the sexual health history around determining previous syphilis infection and that kind of thing. So we've already talked about that, and we will be working on that in the coming months. Most immediately, NCSD and NNPTC are convening an expert panel in early February where we will be working to come up with some shared initial ideas around the ideal populations and venues, some of which you heard already today, where the rapid syphilis test might be best utilized. We're going to put that into a fact sheet that we will distribute widely by the end of February. Again, just as not as a definitive statement on that, but just some initial guidance to help guide the uptake of the product. And then finally, the other thing that we have already talked to Trinity Biotech about, and those of you who know NCSD know that we're engaged in this work, is working on some negotiated pricing for public health. We do know, obviously, that the price for syphilis health check and perhaps future RSTs is higher than you pay for an RPR. We don't think we'll get to the point where they're equal in price, but we have talked with Trinity about some options to try and find some reduced pricing. So those are just a couple things I wanted to let you know were coming down the pike. Mark, I don't know if you want to add anything to that since we've been working so closely together on these things.
No, I think that sounds great. I think there's a lot of good questions that were raised today that I think potentially we still need answers to know exactly how this test fits into our big armamentarium of tests for syphilis. But I think there's great potential in some use scenarios for where this could be really helpful. And so anybody who has or been working on other things, I would encourage you to share them with NCSD because we'd love to be able to hear about them.
Great. Peter, any parting thoughts?
No, it's exciting. We've got some new stuff, and it'll be fun to work together to try to figure out how best to use this.
Great. Well, thanks to you both. Thanks to NNPTC for co-sponsoring this today, and the 150 or so folks that joined us. Thanks so much. And again, you will get an email shortly with an evaluation of the webinar, as well as a link to the resources posted on our website. Thank you, everybody, and have a great afternoon.